This lesson focuses in on the topic we introduced in the last lesson about how the pleural interface, or in other words, the transition point at the junction of the thoracic wall and the thoracic cavity, influences our ability to visualize the lung or make inferences about its health. Now, we're going to zoom in a little bit more and look at the pleural line and consider some diagnoses that disrupt the normal pleural interface. Once again, here's a professional level sketch of the pleural interface, reminding us that the pleura represents two layers of opposing tissue. The parietal pleura lines the innermost surface of the thoracic cage, and the visceral pleura overlies the lung parenchyma. The visceral layer also has double layers or invaginations that dive deep down in between the lobes of the lungs, which explains how lobar infections can remain isolated to one lobe, or how we can visualize things like fluid in the lung fissures on chest x-ray. We'll also look more at how this can affect our ultrasound findings as well. In our last lesson, I introduced the concept of A-lines and demonstrated how the physics of ultrasound artifact generate these echogenic parallel lines, which are essentially just a form of reverberation artifact when no signal is picked up deep to the pleural line. This happens when the lung tissue is inflated and healthy, preventing sound waves from propagating through the lung. While you've seen this as a still image, like the middle image seen here, let's look at what the normal pleural interface looks like on a dynamic image. So here are two video clips of the normal lung and pleural line on B-mode ultrasound. So what we have here is we have linear footprints for both of these probes because we see a straight line right across the top. We see skin and subcutaneous tissue, and then we see a highly echogenic pleural line here at the top with A-lines underneath. Same thing over here, we see skin and soft cutaneous tissue. We see a rib with acoustic shadowing, a rib with acoustic shadowing, and then deep to that, we see this highly echogenic pleural line with parallel A-lines underneath. Now, hopefully you can appreciate that in both of these images, the pleural line seems to shimmer. And if you look really closely, you can even see what looks like specks that sort of travel along the line, sort of like ants walking across this line. This is another artifact that's generated by the motion of the two layers of pleura against each other during respiration. The pleural space is a potential space between these two layers, and normally there's a trace amount of fluid that allows these layers to sort of slip past each other without much friction and helps the lungs be able to inflate and deflate that allows respiration. Sometimes I've heard this shimmer be described as the appearance of small little lines of ants, like I mentioned, that march along the pleural line, and that sort of grainy quality can also be seen in the image that's generated deep to the pleural line. It's imperative that you see this shimmer or lung sliding when looking at lung ultrasound before determining if a lung is healthy or not. So here's a side-by-side comparison of a normal lung sliding and a lung that does not have sliding. So here you see this bright echogenic pleural line, you see a rib with some acoustic shadowing, and then you see this shimmer underneath that sort of looks, you can tell there's a marked difference between this section below the pleural line and this section above. While there is still motion up here, it's not shimmering nearly as much. Now over here on this one, we see a rib and shadowing underneath, but at this pleural line, do you see that there doesn't seem to be the same shimmering motion? There's still motion by the movement of the probe and by the movement of the chest wall, but it's not the same sort of ants along the line, not the same type of shimmer. And that's really, really important as we look into the rest of this module. So while I introduced A-lines in the last lecture, it was perhaps a bit premature of me to mention that A-lines imply the presence of a healthy lung because on their own, they don't. It's important that you see both A-lines and lung sliding to be confidently able to say that there's healthy, well-aerated lung tissue. When we are documenting the lung exams, capturing a view of lung sliding and the presence of A-lines is vital to supporting this interpretation that there's a normal pleural interface. Some conditions, such as a pneumothorax, can still have A-lines present on exam, but they will not show the lung sliding or pleural motion that shows that the lung is in contact with the parietal pleura. So for that reason, documenting a still image alone is an insufficient exam. You can either capture a video clip that clearly shows A-lines and lung sliding, or you can use our good old friend M-mode to show lung sliding over time. Let's look at what that image would look like. So if we place the M-mode cursor over an intercostal space where lung sliding is present, the motion over that line would look something like this. So what we see here is this looks like a curvilinear probe footprint. We see an echogenic area representing ribs with some acoustic shadowing underneath. We see a pleural line, and that pleural line, the M-mode tracer is placed right over that pleural line. And then as a function of time, we see this pleural line representing a bright structure with relatively less motion above it and more motion below. So that pleural shimmer here gets translated into a grainy or like TV static image deep to the pleural line. So some people have compared this to the appearance of a seashore. And so accordingly, this is called the seashore sign. And it's a sign of positive lung siding and is what we expect to see in a healthy lung field. So now that we can identify normal lung appearance, which consists of positive lung sliding and positive A lines, it's time to bring back our central question of point-of-care ultrasound. So in this case, the focus clinical question that we can start to ask relates to what we've learned about the importance of the pleural interface. Since we know that the pleural layers should normally be closely approximated, permit lung sliding, and overlay well-aerated lung tissue, what would you expect to happen in various diseases that affect the pleural interface? Let's focus on the two main conditions that actually result in a disruption between these two layers of the pleura. So first, the pleural space is described as a potential space that can fill up with fluid, be that transitive, exudative, frank blood, etc. This fluid physically separates the two layers of the pleura. Fluid can also, of course, transmit ultrasound waves quite easily, resulting in the loss of A-line artifact, and instead we can visualize structures deep to the parietal pleura. The other thing that can get into the potential space is air, and while air will also separate the two layers of pleura, it does not permit sound wave propagation easily. So here, we'll still get A-line artifact, but we will lose the pleural shimmer or lung sliding. Let's look at both of these in more detail. When we're considering these disruptions, remember that the sensitivity of our exam depends on proper technique. To detect even small volumes of air or fluid in the pleural space, think about where these would collect. Fluid is gravity dependent and will collect at the most dependent portion of the thoracic cavity that it is able to reach. Generally, in both supine and upright patients, this is going to be at the posterior lateral costophrenic angle. Conversely, air is antidependent and will usually rise to the most superior portion of the hemithorax. In supine patients, this will be somewhere along the anterior chest wall, but its exact location will depend a little bit on the patient's individual anatomy and their positioning. If the patient is sitting up, then this will be up higher in the lung apices, which can be a little bit harder to visualize with ultrasound. So let's have a case here of a 64-year-old who has a history of heart failure with a reduced ejection fraction. Last echo showed his EF to be somewhere between 20 to 25%, who ran out of their loop diuretic therapy 2 weeks ago, presenting with 2 weeks of progressively worsening dyspnea. So here on this chest x-ray, which we know we don't necessarily need to order now, we see blunting of the costophrenic angle consistent with a pulmonary effusion or pleural effusion. And then when we do an ultrasound of this, what we see is loss of those A lines, but instead anechoic collection, which we can suspect is fluid here. This is our diaphragm and the liver. And then what we're actually seeing is this is atelectatic lung that looks like a little jellyfish wiggling around in a fish tank. And this is the compressed lung that we're actually able to see because all of the air has been pushed out of it by compression atelectasis from the fluid that is seen here as pleural effusion. Pleural effusions are generally pretty simple collections of anechoic fluid, but every now and then we can get some clues that there may be something a little bit more complicated going on. So in this case, on the image on the left, we see once again the rib spaces up here, we see the pleural line, but then underneath it we see anechoic fluid. But we also see these septations or loculations inside of this particular patient's pleural space. And so this is an example of an infective or exudative effusion. And then over here on the right, we once again will see a diaphragm and liver on the right here. We see the spine, and then we see the lung space. And inside of this anechoic fluid, we see these tight, small little echogenic floaters. They look like little plankton floating around in a pond or ocean. And this is actually called the plankton sign, which can suggest that an effusion is exudative. So we've talked about fluid. Let's now look at air and see how air collection in the pleural space or a pneumothorax affects what we see on ultrasound. So let's go back to this image that I showed you earlier. So here we see normal lung sliding on the left. We see our rib, another rib here, the pleural line, and this shimmer underneath. In this image on the right, however, we still see ribs, we still see a pleural line, we even see some A lines, but we don't see that same shimmer. So in this case, let's say we have a 22-year-old ice hockey player who has increasingly worsening shortness of breath after getting cross-checked into the corner boards, and we do a lung ultrasound, and here we see the pleural line, we see a rib, but we don't see that same shimmer underneath that we normally see. We don't see those ants marching along this pleural line. So this is very suspicious for a pneumothorax. Absence of the pleural shimmer, no anechoic fluid, but we still have A-line artifact present. So once again, if we wanted to quantify this, we could also look at this with M-mode, and this is what I would suggest that you do if you're looking for a pneumothorax. So let's take our M-mode cursor and point it right in the middle of this intercostal space. So if we traced out that image over time, what we would get is something that looks like this. So instead of that sandy beach sign that we saw earlier, where there's a clear delineation here at the pleural line that had grainy texture below it, and then we had the waves and sky above, this has just a set of parallel lines that don't seem to have that same grainy quality. And so this appears much more similar to a barcode, and is called the barcode sign, which is highly suggestive of a pneumothorax. So some of the evidence suggests that if you see a barcode sign on a patient, that it can be up to 79 to 100% sensitive and extremely specific for a pneumothorax, versus a portable chest x-ray for the same patient, as one we might do in the ER, has a very low sensitivity, although it's still a very high specificity if one is seen. So another maneuver that you can do if you do diagnose a pneumothorax is actually take your probe and slide it laterally along the chest wall until you start to see the return of the pleural shimmer. And so here, what we're able to see is in this clip on the image on the right, there's actually a point at which the lung that's in contact with the chest wall comes into view with the respiratory cycle, and then it detracts or retracts underneath this rib again, and we lose sight of it. So we see, if we had a M mode on here, we'd see portions where it would be like a beach, like right now, and then right now it'd look like a barcode sign, because that's the point at contact of the lung and the pleural interface. So that's called a lung point, and it's highly, highly diagnostic of a pneumothorax and can be useful for estimating the size of the pneumothorax. Now, one cautionary point is that if you're looking for a pneumothorax or looking for a lung point, you may not be able to see one if it's a very large pneumothorax, because the lung will completely separate out from the pleura. So this is not diagnostically. You don't have to see this in every pneumothorax that you diagnose, which is hopefully not very many, but it is something that you can look at to sort of prognosticate. So that's a pretty rapid overview of lung sliding pleural effusions and pneumothorax. So in this lesson, we talked about the anatomy of the pleural interface. We reviewed what A-line artifact means and talked about how we need to see both A-line artifact and lung sliding to diagnose healthy lung underneath the thoracic wall. We talked about what pleural effusions look like, these anechoic collections of fluid deep to the pleural line that disrupt the normal lung sliding that we would otherwise see. We talked about using M-mode in pleural ultrasound and how we could differentiate between the beach sign of a healthy lung sliding and the barcode sign of a pneumothorax.